Friends, today we are going to see about NABH chapters. NABH is nothing but National Accreditation Boards for Hospital and Healthcare Provider. So in NABH accreditation we have nearly 10 chapters, some standards and objective elements. So we are going to see in detail about all the chapters, standards and objective elements. So mostly in India, NABH accreditation is the familiar one everybody will go into. See, there are so many accreditation bodies like JCIA, ISO, but still in India we do follow NABH standards. So NABH is most popular nowadays. So we are going to see in detail all the chapters one by one in this playlist. Today we are going to see about AAC, which is Access, Assessment and Continuity of Care. So we will go and check about this in detail. So the summary of standard says AAC 1 is the organization defines and display the health services that it provides. For example, any hospital should have the list of scope of services. When the patient is coming inside the hospital, in the reception itself, they should know what all the services are available here, what is available, what is non-available. For example, if you have only general service, like general medicines and general surgery only, then you have to mention only these services are available. Gynecology is not available means not available, so that they will not wait over there and waste their time. So this is the main purpose. You should display all the scope of services what is available in your hospital. And AAC objective element 2 is the organization has a well defined registration and admission process. Yes, if any patient is coming into reception, there should be a process and it should be a documented policy saying that the so and so patient will come into admission counter. After that you will give some general consent form, they will give a form. They will write all the self-registration forms to be filled, everything they will do. Some hospital they do have some kiosk where the patient itself they will enter their registration. Some hospital they have some manual papers where they will write it and document all their demographic data, everything. And then this will go to vital signs nurse, they will take vitals, and then in some hospital it is like GP will assess, then they will decide about referral to GP, all those things, blah blah, etc etc. What is your hospital policy? It should be documented, and there should be at least one process just to reduce the timing as well as to fasten the process and to get timely appropriate care. So that is AAC number 2. AAC number 3 is there is an appropriate mechanism for transfer in and out of referral of patients. For example, if your hospital may get transfer in patient or maybe you're transferring out some patients, there should be some documented policies to send out and to receive the patient. How are you going to receive patient, through whom, which team will go and receive the patient, and is the ambulance is equipped, is there any forms to be maintained when the patient is coming in or when they are going out, all those things. There should be a fixed process. AAC 4 is patients cared for by the organizations undergo an established initial assessment. So whoever is the patient, maybe a pediatric, maybe a gynec, be it general medicine, anybody, whoever comes, they should have the detailed initial assessment by a registered nurse and a doctor. So you should have some formats for that. And AAC 5 is patients cared for by the organization undergo a regular reassessment. A small example is the patient is coming with 9 score of pain. So you are giving some analgesics and narcotics for the patient. Then after, based on the manufacturer recommendation or based on the quality team of that particular hospital, you will be reassessing the patient within maybe half an hour, or if it is IV injection, mostly within half an hour. If it is oral medication, within 1 hour. If it is narcotic, maybe within 15 minutes you will see the changes. So you have to assess the patient. That is reassessment of the patient. You should have some policy for that. And then AAC 4, laboratory services are provided as per the scope of the organization. So in your hospital, what all the scopes are there? So according to the, in alignment with that scope, you should have all the services available in the lab also. So if you have general medicine, you should have some at least biochemistry, random blood sugar, blah blah, those things. So you should your lab services should match your scope of services. And then there is an established lab quality assurance program. For example, external quality assurance. There should be a quality policy which says at least yearly once or twice your hospital lab should have a external quality. Next point is AAC 8 is there is an established laboratory safety program. For example, your lab should have safety measures like eye washer. Like if you are handling with reagents which irritating the eyes, you should have a proper eye washer machine, and then there should be a proper quality check of all the machines, calibrations of all the machine, and then they have to use properly the PPEs, all the necessary PPEs, personal protective equipments they have to use, and then lab related safety programs, whatever is they are listed in NABL, everything you have to follow. And AAC 9 is imaging services are provided as per the scope of services of the organization. For example, you have a obstetrics and gynecology, then you should have a radiologist and at least a USG machine, so that you can provide radiology services for the antenatal mothers. So according to your scope of service, you should have a radiology services also. Just for X-ray, we cannot shift the patient from our hospital to nearby hospital. So whatever is basic radiology services, you should have. At least if the patient is, you have IMC services, it is better at least one CT services should be there inside. And the reporting may be telemedicine, it's okay, but at least a CT facility should be there. If you have a ventilated patient and all, it's difficult to shift all the patient outside, no? So it's better at least you will have one CT services inside the hospital. So these are all desirable. And the next point is AAC 10, there is an established quality assurance program for imaging services. So for example, you have a radiology department, then you should have some display about the signages of radiation safety, and then pregnancy mothers cannot come inside, and then what are all the critical reports your radiology department is having. And for example, you have a lead aprons. In that case, all the lead aprons at least 3 months in a once they have to go for quality check. These lead aprons we have to take X-ray and check for any cracks inside. And then TLD batches will be there. So translucent dosimetry batches, what radiographers are using. All those things, readings you have to check properly in a fixed interval. You have to check the readings and then make sure they are not exposed to radiation. All those things will come under this. And then there is an established safety program in imaging services, what we have covered already. And then patient is continuous and multidisciplinary care. Patient care is continuous and multidisciplinary. If the patient is coming inside, we have started with some care. So you have to continuously reassess the condition, and the continuation of care from the ER to the ward to IMC to OT to back to post-operative one. It should be continuous and care. There should not be any stop or interruption of care in between because of any reasons like no payment, sisters not available, doctor non-availability, blah blah. There should not be any interruption in the patient care. It should be continuous, and it should be in the nature of multidisciplinary. And the next point is the organization has an established discharge process. So the moment the patient is coming in, the discharge process is started actually. So once if they are coming to ER, we will give some provisional diagnosis, and maybe within a day or next day we will come to the conclusion of final diagnosis. Once the final diagnosis is made, there may be a change in primary consultant. They will be go for second opinion if needed, and if the treatment is done, if the patient is improving, then we have to start discharge process. When the approximate discharge will be there, what will be the discharge medicine, everything should be ready, so that at the time of discharge there will not be delay for the patient. So the discharge process is continuous and multidisciplinary in nature. It should involve all the doctors whoever took care of that patient. And the next one is the organization defines the content of the discharge summary. Usually what are all the things we are expecting? The discharge summary should have a medical emergency, means when to contact and where to contact, what are all the medical emergencies may come, so when to come for next appointment, so what are all the medicines they have to take, how long they have to take, and then what are all the complications they may expect, any side effect is there, means to whom they have to address. And nowadays we are insisting to go for discharge summary in bilingual, so not only in English, If the patient is not aware to read in English, we have to give them in their own language discharge summary, which may not be possible. Still we can write and give for the patient. And these are all the points which comes in access, assessment and continuous of care. Thank you friends. We are done with first chapter, AAC, access, assessment and continuity of care. Next we are going to see care of patient, that is chapter number 2. We will see next video. Thank you.